Don't say the Q word.
If somebody says the Q word in A&E, what happens, Becky?
It's the opposite.
You don't.
Yeah.
I'm convinced it's true. Oh, is it to do with quiet? Don't say the Q word.
Oh,
Oh, sorry, I've just said the Q word.
don't say the Q word.
Today, we're celebrating all things older people with Beth Carey, who is a highly specialist physiotherapist in geriatric medicine at NUH and is the National Chair for Agile, a professional network of Chartered Society of Physiotherapy for therapists working with older people. Beth, hello.
Hello.
Welcome to the podcast.
Thank you very much for having me.
What would you be doing right now if you weren't sitting here with me?
Well, this week I'm shortlisting for jobs, so I've got over 200 applications to shortlist for people wanting to join our team, which is fab to have so much interest, but it's a lot of work to get through that many. So that's what I'd be doing right now. But normally on a day where I'm not shortlisting for jobs, what time is it? Mid-morning. So I would be seeing patients. I'd be getting them out ready to have their dinner in their chair and getting them ready for the rest of the day.
Because your journey,
Yeah.
hate the word journey, sorry, apologies for using that, but your kind of entry into the physio world and this career actually was sparked by an injury as a child, wasn't it?
Yeah. And I always say it's quite boring. It's a very typical physio way to get into the career that we injure ourselves and then we think, oh, rehab's cool. So I tore my meniscus when I was a 15-year-old when playing volleyball. Your meniscus is the shock absorbing part of your cartilage there in little sort of C shapes. That's why they're called menisci. I had an operation during my GCSEs and the recovery was really quite hard for me. Physically, but also psychologically. So it was right in the middle of me taking my exams. I had to wear a big leg brace that kept my knee in extension, kept it straight. I wasn't allowed to bend it at all, which means you're kind of swinging around this big lever. And that was quite tough as a fit and active 15-year-old to then suddenly not be able to move very well, be in a lot of pain, and then try and do your exams at the same time. So the question came up in my mind back then was, well, that's really interesting how this physical injury has affected me emotionally and psychologically. And I became really interested in the mix of the two. And what I now know to be the biopsychosocial model, which is what all physios sort of model their practice on, but essentially holistic or whole person care, looking after not just a joint, but that person as a whole.
Yeah, because actually, and I suppose you can relate this into the work you do now with others and the older people that you tend to be working with, is, you know, the impact, is the emotional impact, isn't it? Is a massive part of it.
Yeah. And I always say, I mean, there's almost no point in fixing someone physically if you can't treat what's going on up here or in here. And the reason we need our physical bodies to be working well is so we can do things like achieve our goals and get around in daily life and enjoy life. Life is about enjoyment, not just surviving. So what I really want for my patients is for them to thrive, not just patch them up, get them better and send them on their way. Yeah.
If it makes you feel better, I've already done mine in my right knee as well. But as a 50-year-old, air guitaring. So
Air guitaring.
I think that's quite a cool story.
That is cool.
Yeah. I mean, the NHS might not appreciate the fact that I was air guitaring and should have been more sensible. But, you know.
I mean, life is about enjoyment. So if you injure yourself air guitaring, then go for it.
Fair enough. Wise words.
Shh. Don't say the Q word.
So the idea was sparked. You went to university.
Yeah.
Talk to me then about the patient who made you think physio's definitely a thing for me.
Yeah. And geriatric physio, this is my lady. So it was actually one of my musculoskeletal outpatient placements. I had a patient come into our clinic. She is someone that had a reverse total shoulder replacement, which isn't when they stick it on backwards. That's what I thought it was. It's when you swap where the ball and cup is in the joint. And it was a lady in her 80s who kind of expected the operation to fully resolve her pain and make her feel really, really better. The primary reason we do it is to treat arthritis in a shoulder joint. What actually ended up happening, which is quite common post-op, is you get a lot of inflammation, a lot of swelling around that joint, a lot of pain post-op. And she was really, really shocked that actually post-op she felt worse than pre-op, which is gutting. So she kind of came into our clinic just really upset and really worried about what her life would look like. She was struggling to do things like open cupboards. She was struggling to lift things and make herself a cup of tea, you know, things that we really take for granted. And until you have a physical injury, you don't realise how much of an impact not being able to do those things, like how it feels. So throughout the weeks of my placement, we sort of treated her. We did physio, which, you know, I won't bore you with all the intricate details. And probably some of it is outdated now, actually. It was a while ago. So there's probably some musculoskeletal physios watching this, like, she doesn't know what she's doing. It's okay. It's not my specialism now. But what really struck me was how a lot of older people we kind of expect them to be in pain, we expect them to be stiff, we expect them to not be able to do things. But the impact of doing physio on this older lady and getting her to a place where she could open her cupboards again, where she could start cooking herself dinner, and the impact that had on not only her physical function, but her emotions around that recovery really, really motivated me in my job. And made me feel really good that I was a part of that. She gave me a big kiss when I discharged her. She was so, so chuffed with her progress. And then that's what sparked me to think, well, actually, older people, what can we do for them? And how does society see them? And how can I play a role in my career in improving older people's lives?
Because you see in the work that you're working with these older patients, of course, in this geriatric care, you believe that society tries to write the older people off.
Yeah, and I think to some extent we do it to ourselves. So as people age, we're like, oh, I can't do that anymore. I'm 60. And I'm a firm believer of age is just a number. I've seen people over 100 years old living on their own, having fabulous lives, going out all the time. But to some extent we do it ourselves. We say we can't do things. And if you say you can't do things, you end up not being able to do them. But also, yes, as a society and maybe as a health service and just in the UK and worldwide in general, we don't push people to get back to their independent selves. So we say, well, you're walking with a Zimmer frame now. Well, that is as good as you're going to get. And that's massively limiting. You can't take a Zimmer frame outside. So if you're walking with a Zimmer frame, we're essentially saying that you're stuck in your house. And I don't know about you. I get massive cabin fever. I cannot spend a day in my house. So I think it really upsets me, actually, the way we treat older people sometimes and how we wrap them up in cotton wool when actually we should be empowering them to absolutely keep going, to get stronger, to get fitter, to keep progressing. And there's a myth, actually, that you can't improve once you get older because we call it your physiological reserve, or how you function is a lot lower. But actually, even with a lower physiological reserve, we can still absolutely see improvements. We can still make changes in people's muscles and in their posture and their balance. We can still improve people to get to a point where they are living the life that they want to live, even if it's a little bit limited or even if they are aging.
I mean, it's quite clear, Beth, your passion and the reward you get from the job you do and why you want to work in geriatric care.
But I think it's really important, actually. What we do is motivate older people to get stronger and to become more independent or maintain their independence. And like I said, live well in later life. That is what we are all about.
And you clearly like the challenge of proving to your older patients, but also to wider society that I'm going to prove to you and they're going to be able to walk up the stairs on their own.
Yeah, absolutely. And I think what's really important as well, I mean, I always say I have the best job in the world, absolutely. geriatrics is the best specialty, absolutely.
Why?
So, well, I think people write us off, oh, you just get people out of bed, you walk them up and down the wards, you put them back, or you put them in their chair. For me, geriatrics almost isn't a specialty of aging, but it's a specialty of really complex, multi-morbid people. So as you age, you often get unwell. You pick up what we call comorbidities in the business. It sounds horrible. It basically means illnesses and conditions, and they can be really complex. And it's a balancing act often in geriatric care to balance one condition with another. So we might give a medication for blood pressure, but that will increase your risk of falling over because it might drop your blood pressure when you stand up. And so I see it as a specialty where you have to really work with the nuance and within complexity to help patients get better. We don't just treat a body part. We treat a patient as a whole and everything that they come with. And we call it the comprehensive geriatric assessment in geriatrics. And it's multidisciplinary. So we do it alongside geriatricians, nurses, OTs, physios, social workers, speech and language. I mean, everyone you can think of in the NHS will input into comprehensive geriatric assessment. And that's why I really love it, because it's so complex and it's so hard and there's not a right answer. It's not black and white. We work constantly within the grey area, but you can see such real improvements. And I think that complexity sometimes puts people off a little bit because it's hard. It's really hard to balance that. And it's really hard not to find a right answer. And as people based in science, we like to find a definite answer. But in health, there often isn't a right answer.
Don't say the Q word.
It's fascinating because, you know, the NHS is clearly doing lots of really good things to lengthen life for people. Life expectancy is getting older. So a lot of things are being done. But then you look at an NHS article like this one, saying hundreds of thousands of elderly people are lonely and cut off from society in this country, especially those over the age of 75. According to Age UK, more than 2 million people in England over the age of 75 live alone. So there'll be people screaming at this now saying, well, what's the point in keeping people living longer because they're miserable? What would your experience be of that?
I mean, first of all, I'd be like, how dare you? Who is it for us to say whether or not someone's life is worth living? If they want to live it, then let's help facilitate that. But also I would look at the cause of that loneliness to start with. And are they lonely because they are physically limited in the first place? So my physio brain goes, well, are they lonely because they can't get out of the house, because they can't access services in the first place? It becomes this vicious cycle. And then that perpetuates loneliness. Are they lonely because people don't visit them because we're really, really busy, in which case that's a societal issue. That's not a health issue. These things are resolvable things. So yeah, we absolutely should keep people going, and you know, someone being lonely is not a reason for them not to keep living well or not to strive to live well.
And actually, as you work with a lot of older patients and you will have conversations with older people all the time, let's end on the positive.
Yeah.
So there'll be lots of people listening to this now, me included, who are getting to that point in life where they think, well, getting towards the next stage where I'll be in that bracket.
Yeah.
And will people want to write me off?
Yeah.
You know, I've learned I can't air guitar anymore because clearly it's not good for me. So what are the benefits? Because, I mean, I can't wait to be in that bracket.
Yeah.
Because I can get away with saying exactly what I want.
Yeah.
And not have to care.
Yeah.
Is that one of the biggest benefits? I mean, you must get brilliant conversations.
I have such wonderful conversations. And really, I wonder if that's why I'm in it, actually, because I'm just a bit nosy and I just love chatting to people and I love chatting to interesting people. Yeah, I mean, recently I can think of a patient I was speaking to who was working in the Korean War. He did a very covert operation in the Navy. So covert, he didn't really have a rank. And he was just airdropped into places. He said he sorted it out and he went home. Some of which was in the Korean War. He said he spent time in Singapore, in Australia. He went all over the world. And just chatting to him, I mean, not only is it just intensely interesting, but it opens my world up as well. It means I can be a more well-rounded, compassionate individual by listening to other people's stories. That's a very exciting story. There are patients that just tell me about their family members that I absolutely love. People that have spent their whole lives in Nottingham, working at the cigarette factory, or in my previous job, they would work down the pits and the coal pits. And you can always tell a pit worker because they'll have deposits of coal in their hands still. So often I'll be treating a patient, I'll be like, oh, which pit did you go down? And they'll be like, oh, it was Pledsley or wherever. People's stories, I find, is what drives society. It's what drives change. It's what motivates other people to improvement. And that is what keeps me going in my job. Absolutely.
What does NUH mean to you then? How would you sum up life working at NUH?
That's really hard, isn't it? Because it's my day to day. And I think the really interesting thing is it's our day to day, but it's not the day to day of the people that we serve. I mean, very much within my team, it's a culture of compassion for our patients, for our team members. It's a culture of development. Again, whether that's developing our patients or looking at what my team's learning needs are and trying to get them to improve. So ultimately we can then improve patient care. But it's really tricky to summarize something that you kind of dedicate your life to day in, day out.
What about your team? You've got to mention them.
Yeah.
If they listen to this podcast and you haven't referred to them, they'll be held to pay, Beth.
Yeah. So I have a really wonderful team that I work within, so the geriatric medicine therapy team. So we're a really diverse team, professionally and in many other ways. We're made up of a clinical lead. We've got a service manager, and then we're highly specialists. So that's physios and OTs. And then we've got senior physios and OTs, and then our rotational physios and OTs that come in and spend 6 months with us and then leave, hopefully picking up loads and loads of skills to take forwards into their career, and then maybe choosing to come back one day. And then we have our really wonderful support workers who are just incredibly dedicated to their craft and really help the team going. I absolutely adore my team. I just think they are so positive and incredibly supportive of one another. And that's absolutely makes it easy to come into work.
Beth, it's been lovely to meet you on the podcast today, and I'll leave it for you to sign off.
Fab. Thank you very much for having me. And just a reminder to anyone out there, please don't say the Q word.
Don't say